Next, Steve Reinhardt is with us this week, and I'll share a bit more about him in just a moment. Next Sunday, we have Laura Evans, an attorney with us, who used to work with Dawn Rupel, and she'll be sharing sort of the legal side of things. And then on the 24th, we will have Stephanie talking about funeral planning. This week, Virginia Bethune and I are going to Zoom together, if that's a thing, and we're going to record a musical program that will then be available on our resources page and nurture page. So be watching for that as well. Also, you can go to the church webpage, and from that, click on the really beautiful artwork that will take you to the nurture page. There's a lot of information there, including after today, that will include resources that Steve will talk about, programs like advanced care plans, medical documentation, and some 5 wishes brochures that we'll get to in a little bit, but I'll talk about that at the end as well. At this point, I'd like to offer a prayer, and then I'll turn it over to Steve. God, we thank you that you are with us always in life and in death, in person and in Zoom. May we know your Spirit's presence among us as we are connected together, as we learn about the magnificent creation of our body, and as we consider what our bodies, the enfleshment of life, means, and how that applies to our living and our dying and our being in you. It's in Christ's name we pray. Amen. When we started this whole sequence, we thought, oh, it'd be fun to have a physician talk about what happens physically at the end of our lives to our bodies, and to talk about provider relationships and all sorts of things. And I learned in that conversation that Steve Reinhardt is a retired physician of 35, 40 years, something like that. So Stephen is at home and is going to share with us. And so Stephen, I want to turn it over to you and say thank you. So you can unmute and take it away.
Okay, good morning. Happy Mother's Day, everybody. As Jeff said, I plan to put up my broad outline of topics I plan to cover, and hopefully I'll move them along as I move along in the things I wanted to cover. And I hope Jeff will interrupt me if I get rambling too far or need to move on. But can everybody hear me okay? I presume so. I'm going to go ahead and share my screen, which should have my outline. Okay. Is that, hopefully that worked. Okay. I guess I wanted to start with repeating the quote that Andy reminded us of from Ben Franklin. This was in 1789. Ben Franklin wrote, "But in this world, nothing can be said to be certain except death and taxes." Obviously, each one of our bodies is going to die at some time. Sometimes that's a sudden event, totally unexpected. Sometimes it's a long time coming with a chronic progressive disease. But it tends to be a shock for family, no matter which type of situation. Some situations are in between, where there may be a long progressive disease, but all of a sudden there's a sudden turn for the worse, kind of an unexpected time frame. So it certainly is desirable for us to do whatever planning we can and whatever communications we can about our thoughts, our feelings about death, and our wishes. I was going to talk a little bit about some of the physiology, the pathways. For a long time, the kind of definition of death was the irreversible cessation of respiratory and circulatory function. And this suited perfectly well until ventilators came along, and pacemakers and heart-lung transplants and some of that stuff. So then there had to be some additional delineation or conversation at least. And now at least all of the states acknowledge total brain death as constituting death. But there's a good bit of discussion, and hopefully we can talk about it later. This requirement of total brain death versus death of the cerebral cortexes or some other possible definitions. But the cardiovascular deaths often are the most sudden, along with something like a very tragic, severe motor vehicle accident or something like that. But cardiovascular deaths most often occur related to coronary artery disease with the blockage of an artery and then disruption of the flow of oxygen and nutrients to the heart muscle, causing arrhythmias and the heart to stop pumping. You can also get a very sudden arrhythmia, ventricular fibrillation, and asystole from a metabolic problem, particularly potassium, either way too high, way too low, other minerals, magnesium, calcium. Some of those imbalances can lead to an electrical heart problem causing our heart to stop. So obviously with these heart things, the heart quits pumping, quits circulating the vital blood with oxygen, glucose, and other nutrients throughout the body. And certainly that's a problem with brain death. Can be due to severe head trauma, or it can also be related to lack of critical oxygen and glucose. The brain needs glucose to perform its metabolism. Other body parts can use proteins, fats, and other sources for energy. But that's where brain death can occur related to low oxygen levels or low blood glucose levels, like somebody with way too much, an overdose on insulin causing low glucose can cause permanent brain damage. Pulmonary death can occur related to either pathology within the lungs, like buildup of fluid, inflammation of the alveoli that interferes with the exchange of oxygen across into the blood from the airways, or it can occur due to lack of respiratory movement. That's commonly what happens in like opiate overdoses, where it suppresses the respiratory effort. And the lungs, the intercostal muscles are not working, the diaphragm, to move air in and out of the lungs. So you can have death related to pulmonary causes that way. Sometimes, however, death can be related to a chronic progressive decline of multiple bodily functions. This is often what happens with cancers, with the aging process. All of our bodies change over time. The human body is so incredibly complex, both at the cellular level of all the different processes that need to go on for a cell to continue to live and function, and for our organ systems to continue to live and function. And our brains are the most complex part of our bodies. You know, the heart can be thought of as a pump. It's a pretty darn good one, where it can potentially last 100 years or even a little more in a few people. And I don't know of any other complex machine that man has ever made that will function as long as the human body can. Human body has a excellent ability to repair some of the minor problems that occur. But as we approach the time of our death with a chronic illness, we can experience both an emotional process toward death and physical changes. The emotional part, we may go through the stages that were listed by Elizabeth Kubler-Ross back many years ago. That was part of our reading in medical school. Not everybody goes through each stage progressively or at the same pace, but most people go through it one way or another. Those stages being denial and isolation as an initial stage, anger, bargaining, depression, and finally acceptance. Many people, as they approach death, will come to be peaceful. Sometimes they seek out to repair damaged relationships, and sometimes that's a sign that a person realizes that they're coming close to death. Physical signs in a person dying can begin with decreased mobility, decreased appetite, often decreased thirst. The person may get a dry mouth, but often not wanting to drink very much. They may sleep more than usual, but have periods of arousal and sometimes agitation, often with the metabolic changes built up of waste products, often with this liver involvement or liver disease, or can be confusion. Along with these decreases in function, often there's decreased urine output, there may be incontinence. The extremities can become cool and dusky or pale. Blood pressure tends to drop. Respirations often become shallow and weak. And actually toward the very end of a person's life, as these metabolic processes break down, there often is what's called chain Stokes respirations, which is bouts of multiple breaths close together, followed by considerable periods of apnea with no respirations. And sometimes this can be confusing. Someone in the family may think the person has died, and they find that 30 seconds later, they start breathing a little bit again. But often that's a sign that all of these processes are breaking down and death is near. Just wanted to remind people that even if a loved one tends to be unresponsive or minimally responsive, it's felt that hearing is probably the last thing to go, and that you should feel free to talk to a person, express your love. Certainly don't say anything that you wouldn't want them to hear when you're there. Hold their hand. We think it's a good idea to be sure to reassure a dying person that the remaining family will take care of each other. Often one of a spouse's greatest fears is leaving the other spouse to fend for themselves or being uncared for. And if those present can reassure that person, that seems to be a source of release. And also mention that it's okay for that dying person to let go, that it's okay to move on. Moving down to my next section there about the common causes of death, just to mention these. I didn't write on the slide, but most of you probably know that in third world countries, the common causes look quite different. Infectious diseases are the most common cause of death in third world countries, most notably TB, malaria, AIDS, and dysenteries. In the United States, heart disease is the most common cause of death. CDC statistics, it takes them forever to gather and tabulate these things, but from 1917, you could see 647,000 deaths from heart disease, cancer at 599,000, going on down the list. Then the considerable drop when you get down to accidents, unintentional injuries, chronic lower respiratory disease, that's COPD, black lung, asthma. Strokes have decreased quite a bit in recent years. Alzheimer's disease is a continuing concern, diabetes, influenza, and pneumonia. And we'll see this year will be different in that category. Nephritis, another kidney disease, and then unintentional self-harm, that suicides, which gun violence or suicide by gun is a very common one in that regard, but also drug overdose and some other things. I put in down at the bottom of this slide about COVID-19. You know, some people deny how serious it is and the deaths. And a few days ago, I saw the statistic that in the 2 months from early March to early May, there were 73,000 deaths. You know, that number is going up. But even if you use, and the first couple of weeks of that were quite low. But even if you go ahead and take that whole 2 months into account, that gives you 438,000 deaths from COVID-19 if the current rate based on the past 2 months were to continue. And obviously that would put you right up in there, which would be the third most common cause of death. But lately there's been a couple thousand per day or even more, and that would even top heart disease if that rate were to continue. So obviously we need to do something about this. Let me move on down, if this works, to the next section. Whoops. Try that. Okay. Now let's talk a little bit more about communication between physicians, patients, and their families. As a physician, we kind of categorize interactions with patients and families in some rough, broad categories. You certainly could consider doing them other ways. One is what used to be called the yearly physical, and now Medicare calls a wellness exam or health maintenance visit, which is usually covered once per year. And this is a time when a number of topics should be covered by the physician, but it's a good time also for patients to discuss, if they haven't already, advanced medical directives. During this visit, physicians should address things like immunization status, anything that's due, person's habits like smoking, alcohol, drug use, also diet and exercise, maybe screen for glucose and cholesterol. Also an important thing is doing screens for depression. Actually, the Veterans Administration mandates that every physician office encounter has a depression screen involved in that encounter, even if you come in to get a work checked. These wellness exams also would include checking to see if somebody's up to date on colonoscopy, mammograms, or anything else that may be due based on their age. I'll talk about the advanced medical directives again shortly in much more detail. Other visits would be some acute visits for an illness, sore throat, or a rash, or the work visit or something like that, or accidents. Sometimes if you call in for an appointment, that you're scheduled for a short visit, and this may be a more difficult time to do a lengthy discussion about advanced medical directives. You may be asked to reschedule. Another kind of, some visits are for follow-up of known chronic medical problems, diabetes, hypertension, heart disease, cholesterol, or many other things. But a particularly stressful time for patients is a visit involving a new diagnosis of cancer or other potentially progressive, serious, and possibly terminal disease. That's like, say, for ALS, Lou Gehrig's disease, something like that, or even Alzheimer's disease or some other things. One of the things the physician needs to do is be sure that the patient and hopefully family members are present, have an accurate understanding of the disease and options for moving forward. It's known that if the word cancer comes up, often patient's mind kind of shuts down. They get this feeling of horror and dread, and sometimes it's hard to hear what information is exchanged after that. And certainly having another family member present can help clarify that later for the patient. It's important that that there's good communication about that there are always treatment options of one kind or another, not always a permanent cure, but there are always things that can be done. And it's important to remind people that they'll never have to be left alone with this terminal or serious illness, that you'll have a healthcare team available. You'll need to recruit family and friends. And it's also important to involve church family for support through these difficult times. One other type of visit would be, say, an acute critical illness where somebody's hospitalized suddenly with a very serious illness, or they're in the stages of terminal care for an ongoing progressive illness. At these times, it's maybe helpful for family to think about how can they communicate with their healthcare providers. In the hospital, it's often helpful to find out when does the doctor make rounds, and when and how is the best way to for family to get information this way. Often a nurse can help with that, or directly when you talk to a doctor, see when would be a good time to do that. Often it's helpful from a physician standpoint if, say, particularly if someone is the patient is incapable of totally relaying any information gained that day, that there be one main family member who's the communicator with the healthcare team, and that one main communicator can then pass along information. If a person is in the critical final stages of cancer, often it's helpful to know when the hospice nurse may be coming in, and that they can be communication with that nurse. Now let's move on to talk about advanced medical directives. If you can see it on the screen, the Code of Virginia has a suggested form, and you can look that up on Google. Advanced Medical Directive, Code of Virginia, 54.1-2984. And that you should be able to bring up the legislatively approved form for an advanced directive. It's a good idea for basically all adults to have some form of an advanced directive. The first thing I've listed here is designating an agent to make healthcare decisions, quote, if I am incapable of making an informed decision. So recall, the patient retains the ability as long as they are competent to make an informed decision. But the person in their advance directive may designate, and in my opinion should designate, the first choice for the person they would like to make healthcare decisions for them if they become incapable. It's critical that the patient talk to this agent, whether it be a spouse, child, or if there's an adult child, or whoever it may be, to both tell them that you would like to do that, and as we'll talk about shortly, to also verbally tell them about your wishes. It's also a good idea to have a secondary agent in case that first designated agent is not available, such as if a person and their spouse are involved in a disastrous accident on 81, and the one who would have been the agent is killed and the other one is incapacitated, then a secondary agent would come into play. The person can go ahead in this advance directive and go ahead and give the agent authority if they wish to, but the vast majority of us want to retain our own capability to make the decisions unless we become unable to. Another element that is very often included, and that at least everyone should consider, if they don't agree with this, they can cross this out on the form. Excuse me. But you may choose, and I'll just read it quickly. If at any time my attending physician should determine that I have a terminal condition for the application of life-prolonging procedures, including artificial respiration, cardiopulmonary resuscitation, artificially administered nutrition, and artificially administered hydration, would serve only to artificially prolong the dying process, I direct that such procedures be withheld or withdrawn, and that I be permitted to die naturally with only the administration of medication or the performance of any medical procedure deemed necessary to provide me with comfort care or to alleviate pain. That can be modified, but that's something that many of us may choose to include in an advance directive. And many of us, even if we're not on the verges or apparent verges of dying from a terminal illness. Let me move the page down here a little bit. There's also room on this form, and it's not mandatory that this state form be used, but it's just an option that helps you fill in the blanks. There are places to customize this, and the customization would really depend a lot on a person's current health status, their age, whether they have dependent children, lots of different factors, but a person may choose to include some specifications about whether or not they would want dialysis if their kidneys fail. Certainly dialysis can be a life-saving procedure. Sometimes it's temporary from an acute kidney injury. Chronic kidney disease may require long-term dialysis. Some people at some stages in life may say, no, I don't think I want to go there. Dialysis can be used as a temporary measure awaiting a kidney transplant. Use of a ventilator can be, again, life-saving for a temporary reversible process, but that sometimes someone, say, dying of advanced pulmonary disease, and may have very little chance of ever getting off the ventilator and getting on, getting back to a life that they can be happy about. I'm glad that they woke up that day. Other things such feeding tube, blood transfusion, IVs, and other things. Many people would maybe want some of these interventions in certain situations, but good things to talk about with family. People should recall that they may revoke an advance directive at any time by, just like a will, you can make a new one when the one in force is the one with the most recent date and appropriately sign. I believe to make changes, you need to have the authorized signatures, witnesses at the bottom. But recall that you can revoke an advance directive or make changes and do that at any time. It's critically important not just to do an advance directive, but nobody knows where that you have it, what it says, or where it is. It's much less useful. It's extremely important that the agent that you've appointed to make healthcare decisions for you, if you're not available, have a copy of this and know what it says. It's helpful also to give to other family members. Also to your primary care physician, any physicians or healthcare providers actively involved in your care, and also at your closest hospital or where you may possibly wind up in an emergency. There is, and I have listed down lower on in this presentation, a website called Connect Virginia that lets you place your advance directive online with certain security measures and a wallet card that you can carry with you that can be looked up with anybody with the appropriate passwords off the wallet card to check at any time. Let's see. I guess moving on to discussion of organ donation. I'm sure you all know that when you get your driver's license or get it renewed, there's the option to become an organ donor. You can also give specific directions about organ donation as part of an advance directive. I believe the most common donation as far as organ donation goes is corneas. These can be obtained from people dying of multiple different causes. Internal organ donation is much more complicated, but it also can be very life-saving for a recipient. These often involve or need to be where some respiratory oxygenation function and circulatory function is maintained until the time the organs are harvested. This is a situation that arises especially when we're discussing the issue of brain death. And I was involved very directly in one of those events, and certainly found that to be very helpful for recipients. Going down, just to briefly mention palliative care. When there's a diagnosis of something like cancer, as you all know, there are lots of different kinds of cancer, and each person's an individual, and each situation is different. Sometimes, very often chosen and probably appropriate situation is to really give every possibility a try for a cure. And often a cure, many cancers can be actually cured. Many can be very effectively treated to improve somebody's quality of life and improve the time that they have with a respectable quality of life. Palliative care, in my mind, kind of falls somewhere between the all out, do everything possible, no matter what the side effects or no matter how small the chances. Palliative care is moving more toward the main goal is for comfort and symptom control, but it still may involve something like radiation therapy to shrink a tumor, knowing that it's not expected to cure the tumor completely, but to shrink it and improve quality of life. Sometimes you can improve pain, such as bone pain, by radiation. Some types of chemo are more a palliative type of treatment than curative. Also, often cancers have suboptimal treatments and continue to progress, or are found at a late stage where the outlook for a cure looks very minimal, the outlook for even shrinking or improving symptoms by radiation or chemotherapy, when you take into account the potential side effects, just doesn't look like an attractive goal. In these situations, it certainly should be a consideration to elect hospice care.
Steve,
yeah.
if you don't mind, I'm gonna draw us to a close here, if that's okay. This is like so much wonderful information. I could soak it in all day long, but I want to make sure we get to a couple questions, and it's about 10 after 12, if
Okay.
that's okay.
Sure.
Is there anything else you want to hit real quickly before we wrap up?
No, I think people can look up stuff about hospice and some of this other stuff. No, let's go down. Did you have questions, or do you want me to use some of my stuff?
There were a couple of questions that popped up in the chat. One of them, I think, is on page 1 of your handout, and that was, what about numbers? What about intentional injury, not accidents, for example, gun violence and suicide, in terms of death rates?
Okay. I'm not quite sure. The gun violence would, I believe, come under the accidental death.
Okay.
Suicide would come under the intentional death. But certainly, as Jim Atwood's books have brought to our attention, gun violence certainly can result in people dying when it's totally unnecessary and preventable. Let's see. Do you want to do that one about death of the body versus the spirit?
Sure, go ahead.
I've got up here under what I've printed, it says questions and comments. As I was looking up some of the stuff, especially on brain death, Duke University School of Law came up with about a 10-page discussion of some of the issues, and they quote, Jeff McMahon further elucidates the higher brain standard of death. He summarizes the view by saying that each of us is essentially a mind. A support for this view, he utilizes the distinction between the human self and the human organism. The self is the person whom we are concerned with, who we are, and whatever attributes make them a person. The organism is the physical body, the housing of the person, and what's left behind after a person dies. As McMahon says, only the organism has biologic life, and only the self has a biography.
So there's a great quote for us to ponder. I'll ask if anybody else has any questions briefly. I want to honor our time today. If you have a question, you want to stick your hand up. Yes, Virginia.
Can we go back to the pictures?
Let's
Oops.
I couldn't hear.
Go ahead, Virginia.
Can you hear me?
Yes.
Okay. Our nursing administrator this week gives us excellent updates on the situation here at Sunnyside, which is at the present wonderful with no cases. But she suggested at some point that we indicate on our advanced directive or something somewhere a code or not code, full code or not code. And I think some people might not understand that, not know the definition. Could you describe code, full code for us?
Okay. Code is starting CPR, okay, artificial respirations and chest compressions in the case that someone has no respirations or heartbeat. If somebody truly does not want CPR performed, no matter what the circumstances, they can do a form that's called a DDNR, Durable Do Not Resuscitate form. Doctors' offices, I don't know if administration at Sunnyside has that. Hospices will have this. And it basically says, don't you ever start CPR. If someone's in relatively good health and has a sudden collapse from a heart condition and they're witnessed and resuscitation can be started early, they may have the possibility to get back to the status they were at before. But if it's a delay or if they have other health conditions, they may say, if I'm that bad that my heart and lungs stop, I don't want you doing CPR, then you should fill out this no code DDNR form.
Thank you.
Thank you, Virginia. I am conscious of our time, and it is 12:15, and as I've said before, I could soak this stuff up all day, and it's so exciting. So there's been a suggestion that maybe we figure out a follow-up session with you, Stephen. So we'll talk more about that and what that might look like. Before I close us in prayer, though, I'm going to show you on my screen, if you can see it, it says 5 wishes. We have copies of this program here at the church. If anybody wants one to fill out or to share with your family, let me or Stephanie know, and we will get it to you. There's also an online portion component element of it, and we're still trying to figure out how to make that work, but we have the paper copies for sure. So that's one way to do that. And so I'm grateful for Stephen. Everybody just clap for me, and a round of applause for his presentation. Thank you. I'm going to close us in prayer. God, indeed, you created us as complex beings. Our bodies and our minds and our spirits are woven together as one, and they are interconnected and they connect to each other. We thank you for this mystery and for the wisdom of those like Dr. Reinhardt, who understand our bodies and help us connect that to our minds and our spirits, so that in life and in death, we can understand this marvelous creation. We give you thanks for Christ, who came among us in body and lived and died and rose again, that we might know abundant life. It's in your name we pray. Amen. Thank you, everybody. Thank you, Dr. Reinhardt.